Okay, so over the next couple of minutes, people will still come in, but I might just get started and give a quick introduction. So again, thank you very much for being here today. This is our African Community of Practice webinar. We have a few more scheduled up until December, and so we're delighted to have Dr. Lara and Dr. Modupe here today. I'll just give a brief introduction. So Dr. Modupe is a public health physician with over 20 years experience, practical experience in leading, planning, implementing and monitoring medium and large scale health system interventions. In the past 12 years, she has led health programs in over 400 primary and secondary health facilities across 12 states in Nigeria and developed practical hands-on expertise in the area of quality healthcare and service delivery. She's also led the implementation of statewide projects and provided support to health systems leaders. To date, she engages with healthcare leadership at federal, state and local government levels, as well as private sector service providers to improve the effectiveness of health service delivery and to strengthen the performance of the health system. She is an ardent advocate for healthcare quality, who is keen on deploying interventions that will produce system-wide impact using methodologies that can reproduce at scale and give results sustainably. And then our second speaker today will be Dr. Lara Adetukasi. She's a medical doctor and public health practitioner with over 10 years progressive work experience expanding access to quality maternal, neonatal and reproductive healthcare. She's currently an associate at the Health Strategy and Delivery Foundation, where she works as a quality improvement specialist. In her current role, she provides thought leadership in the development and implementation of high impact quality initiatives for governing health agencies and frontline workers. She has a master's degree in public health and is project management certified. Great. So on the topic today, I'll just give a brief introduction as well, as the two speakers are going to give a better introduction than me. So over the past 5 years, the Health Strategy and Development Foundation has supported the implementation of the Nigeria Healthcare Quality Initiative in over 130 primary and secondary health facilities. That's in Lagos, is it Imo and Niger State. The foundation has introduced an initiative of post-pregnancy family planning, which can be a life-saving intervention for mothers and their children. So just on the NHQI, this seeks to empower frontline health providers, regulators, policymakers, and community groups to improve the quality of healthcare, thus improving patient safety, maternal and neonatal outcomes, and client satisfaction. So the private sector partnership commenced in September 2014 and sought to achieve outcomes by September 2017. And some of these outcomes are improved governance and advocacy for quality improvement in the country, reduction in facility-based maternal deaths by 25% in 3 years, a reduction in facility-based neonatal deaths by 15% in 3 years, and also an increase in patient satisfaction scores by 30% in selected facilities in 3 years. So that's a very quick overview and introduction to our speakers. Without further ado, I'd like to hand over to Dr. Modupe. So thank you very much, and I hope you all enjoy this webinar today.
Thank you so much, Katrina. Good afternoon, good morning to everyone out there, wherever you are in the world. Thank you for joining us. So just a few seconds, please. So today, my colleague, Dr. Lara Adetukasi, and I will be sharing some of the learnings from the implementation of a quality improvement initiative to increase access to post-pregnancy family planning counseling on the Nigeria Healthcare Quality Initiative, which is the NHQI, the Nigeria Healthcare Quality Initiative Collaborative. By the end of this webinar, we envisage that participants will have an enhanced understanding of the Nigeria Healthcare Quality Initiative, which is the NHQI, learn how to modify the learning collaborative to ensure implementation of change ideas, and be able to identify and mitigate potential challenges that may be encountered in designing a post-pregnancy family planning intervention that integrates quality improvement principles. We're going to be going through the presentation using this agenda. So first and foremost, I would quickly go through the overview of the Nigeria Healthcare Quality Initiative, the NHQI. I would speak to the approach to increasing access to post-pregnancy family planning, that is PPFP. And then Lara will speak to the results and data from other implementers. And as well, she would also touch on the implementation challenges, limitations of approach, and lessons learned. So moving on to the next slide, I'm going to quickly introduce, the organization for which we both work, which is the Health Strategy and Delivery Foundation, HSDF. It's a not-for-profit organization incorporated in 2013 with a mission to improve the quality of decision-making and execution in the health sector. We do this through substantive engagement with key stakeholders, provision of analytical support, and driving innovation. So in 2013, we conducted a national health system assessment to unpack the drivers of the persistent poor health outcomes that Nigeria kept reporting, despite the efforts of government and its partners. We identified governance and facility level drivers and put together an intervention called the Nigeria Healthcare Quality Initiative, NHQI, to catalyze a system-wide improvement in the quality of maternal and newborn health care. And just like Katrina had said, our overarching outcomes, were to reduce facility-based maternal mortality rates, to reduce facility-based neonatal mortality rates, and to improve patient experience and satisfaction. So to achieve our desired outcomes, we deployed 2 quality improvement methodologies. The model for improvement, and I'm sure quite a number of us are familiar with that approach, is actually a structured problem-solving approach. And then the modified IHI Breakthrough Series collaborative model. And really, this model is for the spread of the improvement and best practices identified. As you can imagine, the NHQI, birthed out of a national health system assessment, was designed for scale, to be tested in 3 health market archetypes and to be rolled out in phases. So the health market archetypes were informed by data from the 2013 Nigeria Demography and Health Survey and the District Health Information System, which we call the DHIS2. The health market archetypes were 1, a dominant private sector market typified by Lagos State, a market with relatively equal representation of both public and private providers typified by Imo State, and a dominant public sector market typified by Niger State. The project commenced in 2015 with a prototype phase, and we started off in 60 facilities in Lagos and Imo states. Learnings from implementation in these states, kind of informed the change packages deployed in the prototype and test of scale phases in Niger State in 2016. And by the end of the prototype phase, the collaboratives in the 3 states showed a reduction in maternal and fresh stillbirth case fatality rates to different degrees. If we look at Lagos, we saw a 25% reduction in maternal case fatality rates over a 27-month intervention period. In Imo State, we saw a 34% reduction in maternal case fatality rates over a 24-month intervention period. And in Niger State, which was, our test of scale state as well, but during the prototype phase, we saw a 37% reduction in maternal case fatality rate over an 18-month implementation intervention period. And one of the things that, so people quickly ask, what was the magic here? What really happened? Documentation was a key thing, and as well as the change ideas, the bespoke change ideas that we implemented, to ensure that maternal mortality was, the drivers of maternal mortality were addressed. Stillbirth case fatality rate also dropped by 34% in Lagos State, by 37% in Imo, and by 9%, almost 10% in Niger State. So this was, these were the results we recorded in our prototype phase. In the scale-up phase, which started in 2017, sorry, excuse me. In the scale-up phase, which started in 2017 in Lagos State, the focus of this phase was, more around sustainability of our achievements in the prototype phase. And I'm sure you can imagine that. We had seen what had worked, and we felt, okay, now that we know what works, let's build in sustainability factors into our interventions. So sustainability was the key thing here, with bespoke interventions implemented at both governance and facility levels. And in this phase, we actually set out to achieve 7 goals. One of these goals was to ensure 70% of women who deliver at participating facilities receive family planning counseling. So that's the 7th goal on the slide. And to achieve this goal, we designed and implemented a post-pregnancy family planning initiative. And that's really the topic of our conversation and our discussion today. So moving on to slide 13. So what exactly is post-pregnancy family planning? And I'm sure quite a number of people know that, but I'm just going to define it for the sake of those who don't really know it. Post-pregnancy family planning is the prevention of unintended pregnancy and closely spaced pregnancies in the first 12 months post-pregnancy. So you would probably be wondering, I'm saying pregnancy so many times in a sentence. That is, really, that is it. Post-pregnancy family planning is the prevention of unintended pregnancy and closely spaced pregnancies in the first 12 months post-pregnancy, irrespective of the outcome of the pregnancy. That's the difference with the postpartum and the post-pregnancy family planning, because so many people use the terms interchangeably. For the post-pregnancy, there is a time frame, and the clause is irrespective of the outcome of that pregnancy. This is the approach that we want to use to ensure that the woman, so even if the pregnancy ends up being a molar pregnancy, if it ends up being, a stillbirth, if it's a live child, the client still needs to prevent an unintended pregnancy and space the next pregnancy. This is how she will keep healthy and reduce her chances of mortality and also the chances of mortality of her unborn child. So research has shown that expectant women and post-pregnancy women tend to have reasons to encounter the health system, and quite frequently too. It has been postulated, and it's now even been proven, that these frequent encounters with the health system can be optimized for post-pregnancy family planning by integrating family planning into routine services such as antenatal care, postnatal care, immunization, child welfare, and so on. So that said, we also realize that there are various spheres of influence that limit post-pregnancy family planning, from the broader policy issues through to the health system and its supply side factors, through to the individual and their own peculiar situations, and and biases as well. Limitations abound. And going through this slide, I don't want to spend too much time on this so that we can actually focus on the other things that we wanted to do. But it's good to have an idea of some of the limitations within the health system that one needs to tackle in designing a PPFP intervention. And some of these challenges include provider competence, knowledge and attitude, capacity for continuous improvement usually is very limited in many of people who are not trained. The structures to even drive improvement many times are not in the facilities, and then structure and organization of care process can limit, the implementation of a quality improvement intervention like PPFP. So even essential inputs, like with most things, if the essential infrastructure, the equipment, are not available, then we can't even be talking of proper processes. We can't even be talking of the culture that would support, the process and the desired outcomes coming through. So these are some of the broad areas or broad domains that we realize hinder generally, an improvement intervention, but specifically here, the examples given here are specific to a PPFP intervention. So for us in HSDF, like I had mentioned before, we're going now into the crux of the matter. The PPFP goal was to ensure 70% of women who deliver at participating facilities receive family planning counseling. That's our goal. And this was broken down for us to even, begin to tackle this. This broad goal was broken down into sub-goals. And for the purpose of this webinar, we have taken one of the sub-goals so that we are not, overwhelming our participants and our audience with data and details, okay? So the sub-goal that we're taking on is to improve the percentage of post-pregnancy women counseled on family planning before discharge. So we identified our desired outputs and the outcome. We identified the indicators to track the outcome and the processes that feed into the outcome. And we also set targets for each indicator. So I'm just going to quickly go through this. So if the sub-goal is through the implementation of the NHQI, we want to improve the percentage of post-pregnancy women counseled on family planning before discharge. Our process measures are: 1, we want to increase the number of post-pregnancy women counseled on family planning through the integration of family planning counseling into ANC, postnatal ward and postnatal clinic and immunization clinic. So these are routine services, but we just want to make sure that these services are optimized, for this purpose. And the indicator is the number of post-pregnancy women counseled on family planning. Another process measure is the increase in the percentage of family planning providers trained in quality improvement methodologies. So it's one thing to have the technical knowledge, but when you encounter problems, when you don't see the kind of results that you desire, if you do not understand quality improvement methodologies, you will struggle. So this is why it was key for us to make sure that every family planning provider, yes, they were trained in the technical know-how, but they were also trained in quality improvement methodologies. And our own training platform were our learning sessions, okay? And so the indicator is the number of FP providers trained in QI methodology over the total number of participating facilities. And then the third process measure is the increase in the percentage of participating facilities that have tested and deployed FP change ideas. So it's one thing to be trained in the methodology, is another thing to actually generate change ideas, deploy them, and see the desired results. So we also had our indicator there, and then the final was the outcome measure, which is increase in the percentage of post-pregnancy women counseled on family planning before discharge. And the indicator there was number of post-pregnancy women counseled on family planning before discharge over total deliveries. The post-pregnancy family planning intervention was implemented in the private collaborative of the NHQI. And we had the facilities enrolled in 2 lots. The first lot were enrolled in November 2017, and the second lot enrolled in September 2019. Now, a 7-step process was developed and implemented, for the PPFP intervention. The first thing we did was to develop the engagement strategy by partnering with the Nigerian Urban Reproductive Health Initiative, which is NURI, as they were also rolling out a PPFP program in the private sector in Lagos State. We co-identified the recruitment criteria for facilities and then enrolled the first batch of, the 25 facilities. We ensured that quality improvement teams were constituted in each facility and a baseline assessment was done. So the FP providers in each of these facilities was identified, and then they were trained by Lagos State certified trainers, which was one of the change ideas, that we had put on ground. And as mentioned earlier on, this intervention is a quality improvement initiative, and it incorporates the quality improvement principles of learning and adaptation. So in August 2018, we reviewed the data that was being generated. And then the review highlighted that, some of the information that we needed for our indicators were not really coming through. So this informed a review of the indicators, as well as, the need to conduct another post-line and baseline assessment using a revised tool. And then findings from the second assessment informed the quality gaps to be addressed, the change ideas generated and rolled out at the collaborative level. One challenge that quickly surfaced was the fact that the NHMIS tools did not cater for the PPFP clients. So change ideas around documentation were identified and their importance emphasized, because like we all know, whatever is not documented is not done. We then moved to the seventh step of implementation, which is documentation, data retrieval, analysis, and feedback. Now, on slide 18, the 7-step process was refined by the time we were engaging the second cohort of facilities. We had learned from the engagement of the first cohort. We then adapted our approach, and then we rolled out a 6-step process. And this is, this is just basically how QI also, the thinking behind QI, okay? And the steps were, practically the same. Actually, the interventions, everything the same, but the difference was, number one, we only did one baseline assessment, using the refined tool because we had learned. 2, templates, tools to facilitate proper documentation on FP service provision were now known and readily, deployed. So these were the things these were the slight tweaks in our engagement with the second cohort, but every other thing was the same. The interventions, the approach, the dose of support, the same. Facilities were recruited using the same criteria. The FP providers were trained on family planning counseling skills by the same Lagos State certified trainers. So slide 19 summarizes, the change ideas tested by the FP providers and the QI teams in the facilities. And like I had mentioned earlier on, to achieve an overarching goal, sub-goals were identified. Outcome measures, process measures were identified, and change ideas that will cause the desired improvement were generated and implemented. So I just want to quickly give an example. The sub-goals are like ramps leading to the goal, so e.g., if you want to, for example, lose weight, go from 70 kg to 65 kg in 3 months, for example, there are different ramps you can set in play. The ramp of eating maybe smaller portions of your meal, the ramp of exercise, the ramp of cutting out sugary and processed food, all of this going towards the same goal. And it's the same thing with our own sub-goal here. So we had identified our aim, which is, increase the percentage of post-pregnancy women receiving family planning counseling before discharge. We wanted to increase that percentage. And then we identified a process measure and an outcome measure. So for the process measure, the aim here is increase the number of post-pregnancy women counseled on family planning through the integration of FP services into ANC, postnatal care, and immunization clinic. The indicator is also stated there. The change ideas that we rolled out to achieve this were: one, we trained the designated FP provider on interpersonal FP counseling skills. We ensured that health talks were provided at the ANC, PNC, and immunization clinics. You know, the health talks were meant to generate interest. You know, FP posters, IEC materials were also used and placed in the facility strategically. We made sure that FP counseling and service provision where, you know, the FP provider was present on the days that these clinics were running, so that if anybody, after hearing the health talk, wanted more information, they could just go over to the FP clinic or to the FP provider and get more information. We also made sure that, you know, the FP provider used FP counseling cards in her sessions, and then made sure that documentation of every session, so the counseling session and the uptake, you know, was done. We also made sure that documentation, you know, the NHMIS tool that didn't really cater for the PPFP client, we created columns to capture that information. And then lastly, you know, the main goal, which is increasing the percentage of women counseled on family planning in the immediate post-delivery period. The indicator, we had the numerator, the number of women counseled, and the denominator, the total number of deliveries in the facility. The specific change ideas were: one, we assigned a midwife, you know, to provide FP counseling every morning to postnatal women in the maternity ward prior to discharge. This was not being done before. Before, they were just talking and telling them, come back for postnatal clinic, come back for this. But now we assign them to counsel, to use the counseling cards, you know, to be guided by the medical eligibility criteria checklist, you know, to make sure that the counseling session ended in the woman identifying, you know, the method she would like to take up. So even if she doesn't take up the method now, but she's already identified it, and probably she'll be working and psyching herself up to the time when she's going to be able to take it up. We also encourage them to document this counseling in the modified pathograph. And then we ensured that somebody was assigned to audit modified pathograph to ensure counseling was done and documented. So this is just like a summary, you know, of the change ideas, you know, driving the data we collected to measure the indicators to track our overall aim. So I would hand over to Dr. Adetukasi now. Please just give me a minute to stop sharing my screen so that she can share her screen and take over.
All right, thank you very much, Dr. Dupe. And yes, once again, my name is Lara Adetukasi, and I'll just be continuing from where Dr. Dupe has stopped. So I'll be sharing the results and the data from other implementers, and as well as the implementation challenges and our lessons learned from this intervention. So Dr. Dupe had initially mentioned that we did a baseline assessment, and one of the things that we looked at was we wanted to look at the inputs that were present in the facility. We needed this information to design, to come up with the change ideas that were rolled out. So first of all, we looked at the inputs that were present in the facility in terms of the IC materials that they had. And what we saw that most of the facilities had posters. About 64% of the facilities had posters, but did not necessarily have counseling cards or demonstration models. And then we also saw that quite a number of facilities did not have SOPs to guide their interventions. We also wanted to look at the processes in the facilities in terms of what they were doing in terms of family planning as at the beginning of the intervention. And one of the things that we looked at was the provision of health talks at the various service points. And we saw that health talks was given at immunization about 68% of the facilities, and also had postnatal clinic. But in the labor and delivery facilities, in the labor and delivery ward, only about 23% of the facilities reported to be giving health talks on family planning at this point. We went on to look at the source of referral to the family planning clinic, and we saw that there was a lot of missed opportunity in that. In terms of what we saw was that about 33% of the women who accessed family planning counseling were referred from clinics along the maternal and neonatal continuum of care. So most of these facilities, right, they were giving health talks at the postnatal clinic, where it was only 17% of the women that were accessing family planning from that. And I want to give the numbers now. So in the 25 facilities that we worked in, 17% was just about 47 women in all 25 in the 6 months in which we looked at this baseline data. So we looked at baseline data for a period of 6 months. And what we saw was that 17% of these people who accessed family planning counseling was from the postnatal clinic. And in terms of raw numbers, that was just about 47 women. So in each of the facilities, we were having less than 9 women per month, you know, attending postnatal clinic. And it was a major problem because they also attested to the fact that a lot of women were not coming back for the postnatal clinic, but that was where they were really giving the family planning health talk. So this helps in creating a bonding platform for the reason why they had to begin to counsel the women in the wards before discharge. So that will serve as an early postnatal clinic for the women immediately after delivery. Another thing that we also realized was that there was no documentation of any woman receiving family planning counseling before discharge in any of the hospitals. The facilities actually said they were not doing it, so they were not giving comprehensive family planning counseling. Yes, they told the woman to come back for postnatal clinic, but very few women came back, and they were not giving this counseling before the women were discharged. And then this was a major missed opportunity, which helped in the design of the solutions that we came up with, which Dr. Dupe had earlier mentioned. And the next couple of slides will be showing the results that we saw after the facilities rolled out the change ideas. So after the facilities rolled out the change ideas, one of the first things that would like to highlight was that according to our goal, where we said we wanted to see an increase in the number of post-pregnancy women being counseled, we actually saw a steady increase in the number of post-pregnancy women who were counseled during the intervention period. And we saw this increase in both cohorts, in cohort 1 facility and in cohort 2 facilities. There was an increase in the number of women who assessed postpartum family family planning counseling. So for cohort 1 had about 108 women assessing postpartum family planning counseling in the baseline period, and that's increased to an average of 388 monthly in the intervention period, while in cohort 2 had just about 4 women per month assessing postpartum family planning counseling, and that also increased to 124 in the intervention period. And one of the reasons that we attributed to this was the integration of family planning into the different clinics, just as was highlighted earlier on in the presentation. And of course, that also led to an increase in referrals from this clinic. So we focused on increasing access to family planning counseling in the antenatal clinic, the postnatal clinic, and immunization clinic. And what we saw was that there was an increase in referrals from the ANC clinic. So at baseline, we had 11% of the referrals coming from the antenatal clinic, but in the intervention period, that increased to 16%. Also, we had, for the postnatal clinic and ward, we had 17% at baseline, and that increased to 47% in the intervention period. And then in the immunization, we had 5%, that also increased to 10% in the intervention period. Of course, most of the increase that we saw came from the postnatal clinic and ward, because most of the facilities began to give the women like an early postnatal clinic on the ward, which they were not doing prior to the intervention. So in terms of the women that received counseling on family planning post-delivery, we also saw a steady increase in both cohort 1 and cohort 2 facilities. Of course, the facilities did a lot of work, you know, to get to this point. So we saw for looking at the collaborative together, we saw about a 43% increase. But when we look at it one-on-one for cohort 1, we had a 42% increase from baseline to the intervention period. And then for cohort 2 facilities, we had about 60% increase from baseline to the intervention period. So there were times when we had dips, like for cohort 1 facilities between March and July, there were dips where we had poor data retrieval from the facilities, and we had to enforce the use of templates, which also informed the use of the modified paragraph, which these facilities began to use because it was quite difficult for them. There was a lot of documentation problem, like was highlighted earlier in the presentation because the NHMIS tools did not naturally create for these facilities to capture this. So we had to introduce templates to them in July, which also helped in increasing the documentation and the capturing of this information in the facilities. Also in cohort 2, it was easier in cohort 2, and I think one of the gains of the cohort 2 facilities was because we're able to take learnings from cohort 1 facilities to cohort 2 facilities. So in cohort 2 facilities, we had facilities that had as much as 70 to 80 deliveries per month, but we're not counseling these women. All the facilities were 0 at the beginning. But when we began this intervention in September, 2019, we saw a steady rise in this cohort. And then also when we had a training for them to just reinforce what they were doing, we saw another rise in the cohort 2 facilities. So both facilities increased steadily in terms of the provision of counseling to women in the post-pregnancy period before discharge from the facilities. So looking at our intervention goals, so we had mentioned that we wanted to achieve 4 key things. The first thing that we wanted to achieve was to increase the number of post-pregnancy women counseled in family planning. We wanted to increase the number, and our targets for that was 70%. But for that, we had a 315% increase. So we started at 108 women assessing family planning at baseline, but we ended with an average of 448 women assessing postpartum and post-pregnancy family planning counseling. Also, we wanted to have an increase in the number of family planning providers trained in quality improvement methodologies. Our target for that was 75%, but we trained everybody. So for that, we had 100%. We also wanted to increase the percentage of participating facilities that tested and deployed family planning in the facilities. And for that, our target was 50%, but we ended up with 97%. So, and that I will discuss about that more in the challenges, but we had one facility where there was a lot of, bias from the provider who did not deploy any of the change ideas. So we had 30, out of 36 facilities, 35 deployed change ideas, but there was one facility that, no matter what we said or did, they had been trained, they just did not deploy the change ideas, which are common challenges that are seen in family planning interventions. For our outcome measure, we wanted an increase in the percentage of post-pregnancy women counseled on family planning before discharge. For that, our target was 70%, but we ended at 43%. But for us, that is an appreciable increase, in that most of the facilities actually started from 0. And then we even also had some facilities who actually surpassed the target. But looking at it collaboratively, we had 43% of the women who delivered in our facilities receiving family planning counseling before discharge from the facilities. Now, data has shown that having access to family planning counseling in the immediate postpartum period, can improve the knowledge and attitudes of clients and of women, to postpartum family planning. So if they're able to demystify it within that period, there is a higher chance of the woman taking up a method. So we have countries who actually tested it, and I think that will be the next thing for us. We had countries who actually did it. So we had results in different countries as displayed. For Niger, they went from 0% women picking up a method before leaving the facility to 31% of their women picking up a method before leaving the facility. But talking about the impact of our own project, what we saw was that family planning counseling of women in the immediate postpartum period before discharge improved from 0 to 43%. We also saw an improved integration of family planning services along the continuum of care. So initially what we were seeing was just 33% of people of the referrals, to the family planning clinic coming from clinics within the facility, but that increased to 73% post-intervention. We also saw an increase in the monthly average of number of post-pregnancy women counseled in family planning, which increased from 108 at baseline to 448 post-intervention. what challenges did we see along the way? So one of the first things that we realized was that the NHMIS register does not actually allow for the capturing of this data. So its documentation is really a problem. And for quality, data is everything. If you're not able to document, then we can assume that it was not done because nobody is able to measure whether you're doing what you're supposed to do. So the project indicators were not in the registers. That was one of the challenges that we encountered. And to mitigate this, what we did was to draw up additional columns in the registers for the documentations of the indicators. So PPFP versus non-PPFP. And then we also created templates. We provided templates for the facilities to be able to, capture this data. Another thing that we also saw was poor documentation practice in the facilities. For instance, not all facilities were intentional about documentation of family planning counseling provided. Some, even after the implementation of the project, we still have that challenge where some facilities will say, oh, we did it, but we could not write it down, especially large volume facilities. So we had some facilities, for instance, one of our facilities that had an average of 60 deliveries per month actually struggled with counseling it, with documenting postpartum family planning counseling. So they provided the counseling, but they found it difficult to always go back to document it. What we did was to encourage them to use the NHQI modified paragraph. So what we did, so we've been saying modified paragraph, what we actually did was to include a column in the paragraph which they were using to monitor the woman anyway, that just said family planning counseling received, yes or no. Did it end in a method of choice, yes or no? So we included that to just make it easier for the midwives to be able to document postpartum family planning counseling. And of course, even after creating the modified paragraph, we also saw that it was some facilities, especially in our Port 1 facilities, were a bit slow to adapt to the modified paragraph. And one of the reasons is because, of course, we modified the paragraph and brought it to them, but a lot of them had already printed large number of paragraphs with their hospital names on it, and they didn't want to abandon what they had in stock. So what we just encouraged was for them to, continue to just write the missing data, which is, has the woman been counseled on family planning, yes or no, on the templates which already existed in the facility. And we also encouraged them to document on the registers and templates in notebooks, in whichever document it was that they could document, to ensure that they were capturing this data so that they would know if they are achieving the goal of the initiative. We also had provider bias in some family planning providers. So there were some family planning providers in the facilities that had personal bias based on their religion, which negatively impacted efforts in promoting family planning. Of course, this is not new to anyone working in the family planning space. We know that provider bias is one of the hindrances to the provision of family planning, and we encountered that. What we just did was to, continue to advocate for family planning in the facilities. Now, lessons learned. For us, we had a lot of learnings, and I'll just mention a few. One of the things that we realized was that change ideas can actually be implemented to increase postpartum family planning counseling in the immediate postpartum period. So problem solving using QI principle provides a systematic approach. So, we have showed you a blanket of what the facilities did, but of course, different facilities, the facilities, picked up different change ideas at every point in time to just ensure that they were able to meet the goal of the project, which is actually responsible for the gradual increase that we saw in the results that we saw. The second thing that we learned from this project is that frontline workers are actually responsive and enthusiastic to implement new approaches. Yes, we had providers with bias, but we had majority of providers that were interested and they were responsive and enthusiastic to try new approaches when guided and when on what to do. The second thing that we realized was that talking about family planning in the antenatal period is actually useful. It helps. So ANC health talks should, be promoted. Family planning, talk about family planning, ANC health talks should be continually promoted because we can leverage on that to increase access to family planning. Another thing that we learned is that proper documentation is crucial and is one of the greatest challenges encountered. So HMIS tool should be modified to allow accurate capturing of PPFP data. We hope that this can be, form one of the policies in future to just ensure that these documents are actually capture, this data, because documentation was one of the greatest challenges that we had in implementing this project. And then we also learned that small changes when layered on existing processes can result in improvement. For instance, for the modified paragraph, what we did was to just add 2 lines, and that solved the documentation issue in some of our facilities, not in all, but in a number of our facilities. So we know that small changes when it is layered on existing processes can actually lead to improvement. Also, integrating family planning into the continuum of care may be difficult for high volume facilities. Remember that I mentioned that we had facilities that had 60, about 60 deliveries per month. They found it difficult, counseling the women immediately after, delivery because of the number of deliveries that they have in their facilities. So for this, we recommend group family planning counseling and other customized change ideas, to be applied to help these facilities. Family planning counseling can truly be made available 24/7. So we can actually have, instead of us having family planning clinics as a standalone, we can actually integrate family planning into the other services that are being provided, so that family planning counseling is made available 24/7. And this shouldn't be dependent just on, registered nurses and midwives. As long as we're able to train other people to provide this counseling, then we are sure that family planning counseling can be made available. Finally, we also learned that once PPFP is demystified, acceptance and uptake can improve. So if you are able to counsel these women, if you are able to provide this information to these women, then they are able to accept family planning in the immediate postpartum period and even within the post-pregnancy year, and then the uptake of family planning can be improved. Thank you.
Fantastic. Thank you both very much for that. Wow, that there's a serious amount of work happening. And I suppose the themes that came up even in the comments there were, the issues with documentation and how to record that qualitative data. But obviously it's something that's worldwide as an issue. And I just see there that Dr. Johnson made a comment that he's also involved in post-pregnancy family planning in the private sector in Lagos. So he said that I'm quite excited to know that collaborating with PPFP in the first batch of 25 health facilities in providing service delivery interventions such as capacity building of the various categories of health workers, provision of jobs, aids and tools, supportive supervision, and also ensuring integration of family planning services in MNCH services. They were able to use the key learnings to scale up to additional sites. Yeah. And he says, as a project with the primary focus on post-pregnancy family planning, we have scaled up to additional facilities, making up a total of 240 health facilities. So that's great. Thank you for that. So if it's okay with both of you, we might just get to a couple of questions. Some of them we got early, so they might have actually been answered in the course of your presentations.
Katrina?
Yeah.
Can I quickly, so I also have been looking at some of the questions. I'm just going from the end.
Sure.
So some of the questions in the Q&A chat room, I think we've spoken to some of those because those are data challenges. And I think from how Dr. Lara has spoken, you can see that that was a major thing, even for us. And we kept on looking for ways to address that. But I see a question here from Raj, and I just want to quickly speak to that.
Sure.
It's not in the Q&A chat room, but it's in the chats, in the chat box generally. He says, I have 2 queries. First one is about baseline. Was it 0%? I think there might be some FP counseling program. Okay, so let's quickly address. Yes, Raj, it was 0%. And the reason it was 0% is, don't forget, we're looking at a particular period. We're looking at the percentage of women, post-pregnancy women counseled on family planning prior to discharge. That's within the first, usually if she didn't have a CS, within the first 48 hours. And if she had a CS, normally within the first 5 to 7 days. you know. Many facilities did not have a comprehensive family planning program going on, family planning counseling program going on. They would mention that, okay, make sure, madam, that, you know, come back and see us in the PNC clinic in about 6 weeks, you know. So they might even give a health talk, but they wouldn't actually give that comprehensive, balanced, you know, family planning counseling. And for us, there were things for us to make sure that it was balanced. It had to end up with a method being identified, you know. Tools had to be used, you know, to support this. So the counseling check or cards also had to be used, you know. So prior to this, prior to their training, and Dr. Johnson has spoken. So I had mentioned when I was speaking that we had partnered with Nuri, PPFP, and that's where Dr. Johnson also had said, you know, when we were recruiting our initial facilities, you know, so we had, you know, co-designed things, and they also had provided the trainings and all of that, you know, ensured that the Lagos State certified trainers came on board to provide this training. So prior to this intervention, there really wasn't anything going on. So that's to explain the 0%. And you had said, why 43%? You know, Lara has spoken at length about that. You know, for the different cohorts, we saw an improvement from the get-go. However, it was steady. It wasn't steep. And our intervention period is just 18 months. So that is, we also need to be quite mindful of that. Sometimes by the time you've run this kind of program for quite a number of months, you know, 3 years, you begin to hit the high numbers, you know. So just wanted to speak to that question. There's another one here. Lara, I don't know if you want to quickly address this. So this is from Paul. It's in the Q&A chat. It says, how were you able to engage the service providers without making them feel you were adding them more responsibility and workload? So this is a common complaint. Anybody working in quality, anybody working at the facility level, this is a challenge that is encountered. Lara, I don't know if you want to quickly speak to that.
Yes, thank you, Dr. Dupe. Yes, so for engaging the facilities, of course, initially, the facilities saw it as increased workload, which is normal in every setting because you're asking them to document something that they were not documenting before. You're also asking them to do what they were not doing before. But usually the culture of sharing the data with the facility helps. So we collect data from the facility monthly and we show the facility the data monthly. Seeing your progress monthly kind of like creates like should I call it like an intrinsic motivation for you? The fact that you see that what you're doing is bringing about, you know, results. I think that came in as a lot of motivation for the facilities to continue. Also, the learning collaboratives that we had. So Dr. Dupe had highlighted earlier that we had learning collaboratives. So coming to this learning collaboratives also created kind of like a platform for good competition within the facilities. So when you come and you see that other facilities are doing it, it kind of like makes you feel like, okay, if other facilities are doing it, then that means that I can also do it. So I think those two things actually help the facility in ensuring that those two things motivated the facilities to take up this extra load, especially the fact that they were seeing the results of the work that they were putting into it. Thank you.
Thank you, Lara. So I see another question. It says, what sustenance strategies are employed to avoid relapse into the pre-intervention state? So I want to let you know that with every program, you just have to, you know, yes, we build the sustainability factors into it, but because we are relying on human beings, so the FP provider is somebody who has been identified and trained, and this person can up and leave at any point in time, okay? So there's always that problem, you know? And if in a facility, so don't forget, we're working in the private sector. At times, private sector, especially if the volume of patients, if it's a small volume facility or a mid-size facility, the human resource available is usually not too large, so they are quite restricted there. So you might just have, you know, one person who is really qualified, you know, to be an FP provider in the sense of providing not just the counseling, but also the methods, you know. And if the owner of the facility doesn't see the value of ensuring that this person, the work environment, the work environment, the right incentives are in place, then issues around staff attrition, you know, would always come to play. And it's always an issue that we have to address. Apart from staff attrition, workload also is another issue. And that's one of the things that Lara had mentioned, that some of the midwives, when they would give the full counseling, even to just document it, they felt it was too much work. You know, why am I, you know, repeating or, you know, giving myself extra work, you know? But as long as you can make people understand, see reason, what data does, you can use this data to argue for more staff in your facility. You can use it to present to the MD that you're doing a good job, that you're actually bringing in clients to the facility. So there are different ways that you can use the data to advocate for better work results, you know, so that's for the provider. But in terms of, are there other things? We just keep training. We have an induction system in place. We have, you know, training of a hand down or a step down process, so that if one person is trained, other people too are trained. You know, all the knowledge is not resident in one person. Okay, we try to standardize the process, so it's not just focused on one person. So Lara, I don't know if you have one or two things to say to that. Any additions? Are there other things we can put in place to ensure that the gains we have seen, the facilities do not relapse?
Yes, Dr. Dupe, thank you. So for the other interventions, so of course, we only gave you a snapshot of family planning. Of course, we have also helped the facilities to build quality structures in their facilities, and we have trained them and looked for a way of ensuring that they are able to embed these QI systems in their facility. And hopefully, as long as they are able to keep these QI structures in place, they are able to continue to provided. Also, over the months, we have coached and mentored this facility and held the QI teams to be able to do continuous performance review. And we, as at the point when we were leaving the facilities, we're already collecting data and reviewing data by themselves. So I believe that a continuous review of their data should help them, you know, identify gaps, if any occurs, if they begin to relapse into the pre-intervention phase, and then come up with change ideas by themselves, since we have been able to equip them with the ability to do so. So the QI structures that we have built in the facilities would also help them in sustaining these interventions. Thank you.
Thank you, Lara. So Catriona, I see that we're at the top of the hour.
We are, and we have so many questions coming through. Would it be okay if I send the questions? I can get them all in one place and then send the questions to you.
Yes,
maybe you could type an answer, and
yes,
then I can circulate to everybody, because people are very interested in this.
Yes, I will do that. Lara and I will do that.
That's wonderful. We could probably have done another hour, to be honest. It's a great discussion.
Thank you so much, Catriona, for having us. You know.
No worries. It was a pleasure. It was a pleasure. Okay, take care. Thanks everyone for coming.
Thank you, everyone.
Thank you.
We'll get to all your questions. We'll send the answers down. Thank you.
Perfect.